We will go on to our third speaker, Dr. Vinay Garodia. Dr. Vinay Garodia is again another individual who needs no introduction, who's a founder and director of the Visitech Eye Hospital, senior eye surgeon with great skill sets, and he's going to be showcasing his case of a white intumescent cataract. On to you, Dr. Vinay.
Thanks, Chitra ma'am, and thanks ARC for giving me this opportunity. So today I'll be sharing something interesting which I have been practicing for the past few months, and I thought I'll just take an opinion of all the panelists out here to see the most difficult challenge that we face is management in a white cataract is initial rhexis. And as we know, the biggest bugbear is if it's a very intumescent cataract, you make a neck and immediately the thing spreads on to give me an Argentinian flag sign. So what is interesting to note is that whenever we give a neck at the peak, at the central area, it's often the other end which we are not actually bothering much about. From there, the thing tends to extend towards the periphery because that's under a huge amount of tension and the thing just goes downwards, slopes downwards. So the only sure shot way of avoiding a Argentinian flag sign is by either doing a Zepto or a femtocapsulorhexis, but unfortunately, most of the patients who come to us with this kind of a cataract cannot afford this. So what I have been doing for the past few months, that rather than giving a central neck, I initiate my rhexis from the periphery and I go circumferential. So if you can see in this particular case, in the periphery, because that is the area which is not very tense, and the chances of this particular part of running this side is very low because it's in the down. It has to go uphill from there, and there is not much of a pressure in the periphery also. So here you can see that you are not touching the peak of the cataract in this case. You're just kind of making a parallel track all around, and this way the rhexis I have found in my cases, my incidence of extensions has gone down significantly. And you can see all through the pressures are quite nicely maintained. I have not made the main port, so I just make it from the side port only. And now you can see that there was a whole amount of fluid that was trapped inside, but because the chamber was so stable, and mind you, I'm not using any hi-fi viscoelastic, it's just simple HPMC that is being used. Now this is another case, similar case where you can see the fluid-filled eye. Again, we are making a peripheral rhexis. And most of these cases, I'm able to manage with the needle alone, though I'm keeping my Banaji forceps along with me in case I need to use the forceps. But because you give the nick in the circumferential manner, and the other end of the nick is also not radial, so therefore the chance of extension is significantly minimized in these cases. I've been doing that for a regular basis now. And in fact, the video I sent to ma'am earlier did not have my third video, which I'm going to be showing. Now, this is a patient, 19-year-old gentleman with a silicone oil-filled eye, and his retinal condition was not very good. So just for the cosmetic reasons, we are doing a cataract surgery. And you could see that there was already silicone oil bubbles inside, silicone oil inside the eye. So there's a huge amount of upthrust. It is a young patient with intumescent cataract. And even here, you can see how beautifully the whole rhexis proceeds. In fact, I had the forceps lying with me, and I was thinking that I'll probably be needing a forceps in this particular case. But since the things were progressing fine, and I'm keeping a viscoelastic on the syringe here, you could just inject the visco in between. The whole procedure goes in a very controlled manner. And you can see that I could manage to finish the whole rhexis with just the capsulotomy needle only. I don't like to exchange the instruments in these cases if it is not necessary. So therefore, I keep the forceps with me. But if the things are going fine, I don't change. So you could see that was such an intumescent cataract. And actually, the rhexis time was about 2 minutes. The total surgical time was about 6 minutes only because there was hardly anything much in this case to be done. And what you can notice, there's a huge amount of plaque behind and there's a silicone oil behind. And even after putting the oil, IOL, I had to inject some bit of air immediately to prevent any oil from coming forward. So this small difference in the technique has really made my life much easier. So I would like opinion and feedback from the panelists and the other presenters out here to give their feedback and let me know if this idea can work for others also.
Yeah, now I would like to take this question. I would take a question from you, Mohan, after this. Dr. Mahipal, are you there?
Yeah.
Yeah, I always believe that you have to make a nick in the central part of the anterior lens capsule and not the periphery, because if you go to the periphery, the chances of extension is more. And then again, a linear again C-shaped. I would want to know what is your thoughts about it.
So actually, I think Vinay has given a good tip. The only thing where I would wish to agree with you is that he was pretty much peripheral, at least the last case that I saw, though he was pretty downhill in the sense that I think it was more of a 6 point, rather a 7 millimeter rhexis that it was. So whenever you're looking at an intumescent cataract, small is better. You start with a smaller rhexis and you could spiral it and extend it. So even his technique can be done for a smaller rhexis, and that is what we will. And at times the forces are not under your control because the lens is so intumescent that whether you give a circumferential or a linear nick, the fluid just comes out, and that's a problem. So Mohan will be talking possibly of his puncture rhexis, but I feel the second thing, Vinay, is that it's always better to work through the side port rather than the main port, because the leakage is much less and it is better controlled. And obviously the best is the femtolaser assisted cataract. It hasn't failed me in, I would say, about 95% plus cases, because we are working on a closed chamber rather than an open chamber in there. But anyway, a good tip, Vinay, as always expected from you, a good, efficient surgeon that you are.
I think
So that's
it
what
works in your hands somehow. Ramurthy, would you want to add anything on this?
Very nice tip of taking the starting the rhexis at the periphery. I think not many of us would have thought about it. I would have just made it more circumferential neck rather than a radial neck, and as Maipal said, taken it a little more centrally rather than going at 5-6 millimeters, because there's always a tendency for it to run off. And especially in really intumescent cataracts, maybe you have done it if there was significant upthrust. Whatever be the way of proceeding with the initial neck we make, I always try to, once there is a significant opening that is there, I like to take out some lens material from the back so that, you are able to match that, and also inject some high molecular viscoelastic in the area where the rhexis has not gone. That sort of balances out and gives me a more planar surface for having a more controlled rhexis.
Yeah, tamponading with the cohesive viscoelastic and a decompression would, I mean,
think,
somehow you are maybe a great surgeon, so you got away with it.
No, ma'am, it's not that. I mean, what I would like to point out that most of the time, if you see if I would suggest every one of us just go through your videos where you had Argentinian flag sign. Normally, what happens when you start at the peak, you are taking care of your main edge that you are trying to make it circumferential immediately. But the other edge of the neck we often ignore, and it is that edge which is actually going out radially. When you're starting in the periphery, that edge is very unlikely to move uphill and kind of pass on radially. So that is the biggest advantage that I have found. When I did once or twice, I thought it was just like, it was just a flash in the pan, but I have been doing it regularly now. And after sending my video to you, that was about 2 weeks back, I've done 3 more cases. And I'm telling you, this one works beautifully. I would request everyone to just give it a try in your OT, because this is a very simple idea, looks very unconventional, but it works beautifully at my center. So I'll just my personal experience would be my rhexis run out rate has gone down significantly by this technique. I'm able to perform a good rhexis in about 90% of cases with this thing without any problem. Which is
you have had a runoff of a rhexis. I want the expert panel to open. If you've had a runaway rhexis, if you're able to get it back by that little Brian's technique, it's fine. But otherwise, what would any of y'all do if you've had a rhexis extension? Yes?
Yeah. Shall I answer?
Yes.
Well, you can put in what do you call, in the side port, you can put a micro rhexis forceps and try to bring the rhexis back into the, and put in a good viscoelastic like viscoat, can do that as well. Despite all these things, if it still runs out, then you can convert one half of the Argentina flag sign into a semicircular rhexis, the other half into a semicircular rhexis, and go ahead with the direct chop technique. Provided the cataract is not very hard, you have to make sure up till grade 2, grade 3 cataracts you can probably manage, or probably bring the cataract into the iris plane and introduce viscoat into the to make sure that the cornea is well protected. And then you don't mind losing some endothelial cells, but you don't want the rhexis to run off to the across the equator to the posterior capsule and lose the.
Have you all ever thought of creating radial incisions on the opposite side, which counterbalances this force and
No, I have not done it. But I want to raise a point on Vinay, because I've done a lot of work on this rhexis in intermittent cataracts. And there are 4 components as far as the intermittent cataract is concerned. There is a pressure underneath the anterior capsule. The nucleus is bulky. There's a pressure in front of the posterior capsule. You're not addressing that also. So that at all. And there is also a positive vitreous pressure in these patients. All the 4 components you have to take care. Otherwise, you will lose. And starting from the periphery is actually not a good thing, because you are doing it well because you're a good surgeon. But if you make the rhexis, Maipal, I agree with Maipal as well as Ramurthy. If you make the rhexis go for a bigger rhexis, you're more likely to lose these rhexis into the zonular area that is 6 or 7 millimeter, and likely to lose the rhexis forever. So that is, I think. Another thing what you can do is probably you can just put a 27 gauge needle, aspirate the front component. Then you can go from center or periphery. Doesn't make a difference. You aspirate the thing, decompress the front component. What the punctorhexis does differently is, because it's a bigger needle with a phaco, it goes down and aspirates the front as well as the back. And also, because with the phaco power you are giving, you're emulsifying the nucleus and debulking the nucleus, pushing the nucleus back. So as soon as you open this thing in a type 1 cataract, what happens is the nucleus, which is very bulky, comes forward, and that is the reason for the Argentina flaxen. So all these problems.
Vinay, one question to you. Your basic hypothesis is that the paracentral area or the peripheral area does not have the kind of upthrust that is required, right? That's what you are trying to say. And there is no way for it to go uphill on the other side.
And also because there's not a radial kind of a cut, because what happens when you go in with a needle to try to make a cut, the needle actually gives a linear cut, and that kind of just goes across the 2 sides. So here, your things are circumferential, so the chances of extending in a radial direction is very low.
Vinay, before you start the circumferential, you have to have at least a beginning of a radial, right?
No, we are kind of making a V-shaped kind of a cut that is happening. So both of them are kind of circumferential. So if you notice, when I'm raising the flap, it is kind of a V-shaped thing. Both of them are circumferential. There's no radial component that is there in this.
And where do you actually wish to start? So wouldn't it depend on the how much of intelligence it is? Because in the last case, I think you started at
last case was a bit more peripheral. I agree, but I would like to start at around 5.5 to 6 millimeter zone, basically outside of the peak. But I want to make sure there's no radial cut that is there, because any radial cut in a tense capsule will run away. Is likely to run away. Whereas if you're making a circumferential cut, even if you leave it for a few seconds, the things don't kind of go downhill from there, because the force direction is in a circumferential way.
Going downhill is not the point. What you made the issue, which I am also trying to recollect, is that it stretches onto the other side. So there's no possibility of it stretching to the other side. That's, I think, the basic thing that you are trying.
And plus, it is a circumferential nature of the cut, which is kind of not going across.
Okay.
Dr. Chitra, may I say something?
No, I think we go on to the next speaker. It's 15 minutes already. We have lots of So
Thank
we
you.
shall go. Yes, interesting case. We'll try doing that when we are ready.